So we just saw one of the CNS's newest products, and we're going to go back and now look at one of the CNS's oldest products, neurosurgery. We asked the neurosurgery to identify several important articles in their from this year, and the highest impact manuscript came out as comparison outcomes in 3,725 overlapping versus 3,633 non-overlapping neurosurgical procedures using a single institution's clinical and administrative database, presented by Dr. Zygourakis.
Hi, good morning. I'm Corinna Zygourakis, and I'm a fellow at Johns Hopkins, and I'm very excited and honored today to talk about some work that I did as a neurosurgery resident at UCSF, looking at patient outcomes in overlapping surgery. Here are disclosures, and this work has already been published in Neurosurgery. So first of all, there are a lot of different words out there for describing concurrent or overlapping surgery, running 2 rooms, simultaneous surgery. So the official definition of overlapping surgery has been produced by the American College of Surgeons, and this has been reinforced by a joint statement from the AANS, ABNS, CNS, and SNS. And basically this states that overlapping surgery is performed by the same surgeon in different ORs with overlapping procedure times, but not an overlapping critical period. In contrast, concurrent surgery is that which is done by the same surgeon in different ORs, but actually has an overlapping critical period. So why do we care about overlapping surgery? Well, we all know that it's recently come under intense national scrutiny, and many of us are familiar with a Boston Globe article highlighting this practice at MGH, as well as an unfortunate outcome in a spine patient. And this led to a pretty significant U.S. Senate inquiry, which was led by Senator Orrin Hatch. And he said, "We're concerned about reports of patients not being informed that they may be sharing their surgeon with another patient. And we're especially concerned by reports that in some cases, steps have been taken to actively conceal this practice from patients." We perform overlapping surgery frequently at UCSF to improve efficiency, promote surgical education for residents and fellows, and also to allow timely access to our high-demand surgical subspecialists. But despite this, and despite the investigation from the Senate, up until very recently, there was actually very little published data in the peer-reviewed literature about the safety and efficacy of overlapping surgery. So the goal of our work was to evaluate the operative time and patient outcomes in overlapping versus non-overlapping neurosurgical cases at UCSF. And we did a retrospective review of over 7,000 cases that were done by 9 neurosurgeons who each did more than 20 overlapping procedures during this period of time, from 2012 to 2015. And we collected a lot of dependent variables, including the patient's age, gender, ASA status, their severity of illness, risk of mortality, the type of admission, whether they came from an ED or were transferred from another hospital, their insurance, source of transfer, what type of procedure it was, when the surgery was done, and whether a resident or fellow were present. And for outcome variables, we looked at the procedure duration in minutes, 30-day unplanned return to OR, 30-day unplanned readmissions, 30-day mortality, as well as acute respiratory failure, severe sepsis, estimated blood loss, length of stay, and discharge status. And what we found, first of all, is that different types of neurosurgical cases are performed in an overlapping versus non-overlapping fashion at our institution. And specifically, overlapping cases have younger patients. They're more likely to have private insurance. They have lower ASA status, severity of illness, risk of mortality. And these are more likely to be routine elective admissions that are referred from physicians. So overall, these are younger, healthier patients who are undergoing these overlapping procedures. The most commonly performed overlapping cases at our institution were transsphenoidal for pituitary tumors, craniotomy for aneurysm clippings, and suboccipital craniotomies for microvascular decompressions. And we found that our overlapping cases had a higher number of co-surgeons and were also more likely to have a resident present. Here we can see in our univariate analyses that overlapping surgeries are longer, 214 versus 172 minutes of procedure time. They also have longer overall in-room time, 296 versus 249 minutes. EBL, however, is lower in the overlapping versus non-overlapping cases, as is the length of stay in the hospital. And looking at several additional outcomes, we find that discharge to a place other than home was lower in the overlapping cases, 30-day mortality was lower, and acute respiratory failure rates were lower in our overlapping versus non-overlapping cases. So you'll say this is not surprising, which is correct, because our overlapping cases were done on younger, less sick patients. So then we also did a multivariate analysis where we controlled for the type of procedure we were doing as well as the patient demographics and the clinical indicators. And we found that there was not a significant difference in return to OR, 30-day readmission, 30-day mortality, acute respiratory failure, severe sepsis, or discharge to home when we were comparing the overlapping versus non-overlapping cases. And the only significant difference in the multivariate analysis was the procedure time, which was on average 30 minutes longer in the overlapping cases. So in summary, across all neurosurgical procedures at UCSF, we find that overlapping surgeries were more likely to be routine elective cases with less sick patients. And after controlling for procedure type, demographics, and clinical indicators in multivariate models, overlapping surgeries were significantly longer but otherwise had equivalent patient outcomes. So from this, we believe that overlapping neurosurgery can be performed safely and efficiently at UCSF. Its advantages are that it allows us to provide more care to patients sooner during daylight hours, to deal more efficiently with urgent and emergent cases that may come in, and also to encourage resident and fellow autonomy and operative experience. But it's very important that overlapping surgery adheres to certain guidelines. Patients must be explicitly informed about overlapping surgeries and the extent of trainee participation in their surgery. These surgeries should be carefully scheduled and well planned, with a backup attending immediately available. And surgeons should be prospectively collecting data and reviewing their outcomes on their overlapping surgery practices. Several important limitations. One thing to note is that the attendings who run 2 rooms at UCSF are all mid or senior level surgeons with many years of experience post-residency, high case volume, and case complexity. Obviously, we did not capture every outcome or complication in this study, and of course, it's a single-site retrospective study. So our results may not be generalizable to other sites that don't have trainees or they don't have the appropriate infrastructure to support overlapping surgery. But it's important to note that over the past few months, other groups have come out with similar findings of safety and efficacy of overlapping surgery, including UCSF Orthopedics, Utah Neurosurgery, as well as the BNI group. So going back to the Senate committee, they did release a final report from their investigations, and they essentially called for a prohibition or ban on concurrent surgeries. These are the ones where the critical period is overlapping in the 2 rooms. And more specifically, the committee said that it was very concerned with patient safety. And so for all institutions that receive Medicare or Medicaid funding, they want, 1, to develop a concurrent surgery policy, preferably banning concurrent surgery, which is when critical period of surgery is going on in 2 rooms at the same time. But for overlapping surgery, where the critical portion of the procedure is not going on at the same time, they want to make sure that we have appropriate policies in place to do this safely. So that includes formally identifying the critical portion of particular procedures to the extent that that's practicable, to develop processes to ensure that patient consent is obtained, to make sure that the backup surgeon is prospectively identified, and also to develop mechanisms to enforce these guidelines and policies and monitor outcomes. They're also concerned with improper payments And so they're calling for an investigation of payments for these overlapping and concurrent procedures. And specifically, while there are currently no billing requirements that apply to physicians who are doing these in the non-teaching hospitals, they're calling for an investigation into billing for overlapping surgeries in non-teaching hospital settings as well. So I really want to thank several of my mentors at UCSF, Mike Lawton, Mike McDermott, and Praveen Mumaneni, as well as my current mentors at Johns Hopkins, Nick Theodore, my fellowship director, and Henry Brum. And